Welcome, and for those of you who are visitors to the ISSC year-rounds, I'm David Henry from ISIS. Welcome. This is the last round of the year before the summer break. As an Australian, I still don't get this summer break idea because we have summer all year round, so we take our breaks in sensible bite-sized pieces, but in Europe and North America, of course, you all insist on going off for a decent period of time. I think it's got something to do with the weather the rest of the year. Anyway, this is the last, and I think it resumes in September.
The day after Labor Day.
Okay, all right. So we have this break, and I think it's good. It's a great relief to everybody. However, in the ministry, of course, work keeps going, doesn't it? And we're very fortunate today to have JoAnne Heale from the ministry, specifically from the Health Analytics branch. And JoAnne's got a very interesting CV. She is a very experienced analyst at the Health Analytics branch at the Ministry of Health and Long-Term Care, a part of an organisation that we do a lot of work with, and a very important relationship for us at ISIS. Now, JoAnne has a number of interesting features in her background, which I have to tell you about. She's a graduate of both Laurentian University and the University of Western Ontario. She did her Masters at UWO. She's worked in a number of organisations over the years, and they include the Wellington Dufferin Guelph Public Health Unit, the Waterloo Region Wellington Dufferin District Health Council, and I guess that was before the days of the LINs. It was preceded the LINs, I think. Yeah.
That's why I left. They were no longer.
As well as being a health information analyst for the different organisations in the past, JoAnne's done quite a lot of other things in her life, and very specifically, and I think she still is, a fitness coach. You still do that?
If I could walk properly. I've had a problem walking the last couple of days.
And maybe suffering from the effects of a little bit of overtraining in the past. Yeah, because at one time held not only former marathon runner, but I think held the women's marathon record. Not only for Ontario, but I think for Canada. I mean, this is serious stuff. Yeah.
Has nothing to do with injury. Maybe everything to do with injury.
She is going to talk today about injury. Now, from our point of view, not only the topic is interesting, but the work that JoAnne does, because she's in the area of the ministry that is responsible for IntelliHealth, and I think has a really important role in IntelliHealth. IntelliHealth is important because this is a very significant portal to acquire some really quite sophisticated analysis from the routinely collected administrative data. And IntelliHealth, as you know, is a significant portal, and is also increasingly available to an increasingly wide range of organisations in Ontario. So it's important for us to be aware of IntelliHealth, its capacities. The Health Analytics branch itself has very substantial analytic capacity, and of course we get many data sets from the Health Analytics branch. It's not, I don't think, JoAnne's specific responsibility to work to provide us with data, but she's working in that area of the ministry that we have a close and very important relationship with. Now, today she's going to talk about the use of administrative data, a topic very close to our heart. And what you're going to talk about, specific topic today, is examining preventable injury in Ontario. It is a very significant area of inquiry, and it's quite unrelated to your efforts in the marathon course, and the fact that you're unable to walk just as well as you would like to, JoAnne. But preventable injury is an important topic and one close to us. I'm sorry Don is not here today. He's out of the city, I think, Karen. Otherwise, he definitely would be. So this is a topic which he's very interested in. So, JoAnne, you're very welcome. Look forward to your talk. Thank you very much indeed for coming.
Thank you for the intro.
Cheers.
I should take that off my CV. I had no
idea. I don't know. I mean, God, for most of us, that would be a lifetime achievement and so on. So don't take it off.
You know, as you become a grandparent, maybe that should go. So the topic, as I have on the slide is using administrative data, and in particular I'm going to speak about the administrative data sets that are available to the Ministry of Health and Long-Term Care. There could be other administrative data sets such as assistive devices that might be very useful in exploring injury, but I will focus on the ones that are available through the Ministry's data repository. So this is what I'd like to cover. Administrative data sources for external causes of injury. And so when I talk about external causes of injury, and speaking of ICD-10 codes, I'm talking about the V to Y codes. But I'm also going to mention the nature of injury codes, because you can't really talk about one without the other. You can't talk about neurotrauma. Neurotrauma is a huge topic, especially in the hockey world right now, and so the external cause that results in a particular type of injury is an important aspect to consider as well. So I'll also talk a little bit about looking at the administrative data sources and looking at the V to Y codes as opposed to the S and T nature of injury codes. I'm going to look at what we can do at the Ministry with our data repository around direct linkage of external cause data to other administrative data sets, because not all administrative data sets have the ICD-10 V to Y codes in them. And then I'm going to give you some examples where we can use the administrative data to look at evaluating policy, and specifically I'm going to look at graduated driver licensing, describing health status. I'm going to look at deaths, but those three major causes of external causes of injury: motor vehicle, suicide, and falls. And then how you can go about calculating the burden of disease from the administrative data. And then I'm going to look at preventable injury, focusing on the Haddon matrix around host, event, etc. factors in injury prevention, and how you can get at those particular factors, what are influencing external causes of injury through the administrative data. And I should also say, it's not a really large group, and feel free to ask questions as I go. My presentation's probably about 45 minutes, but it's sometimes better to ask throughout rather than save your questions for the end, and I don't mind at all. So first of all, looking at those two groups of codes that are related to injury. The nature of injury, for example, a head injury, that's represented by the ICD-10 diagnosis codes S and T, versus the external cause that resulted in that head injury, such as a motor vehicle crash, that's represented by the ICD-10 V and Y codes. And where can we find them in the administrative data sets? So I've got hospitalization data. Most of you are probably familiar with the DAD, the Discharge Abstract Database from CIHI, and the Ministry in its data repository has the data feed from CIHI. So we have all of the final data sets in multi-year data tables, so you can query multi-years at once, and then we also have the interim data as it comes in. So right now we have up to, we just posted the accountability cut, so up to the full 2010-11 fiscal year of data, but only interim right now. It's not the final data set. But in the DAD, in nature of injury, you have ICD-9, it started with codes from 1996 to 2001, and then ICD-10 began in 2002. And that diagnosis, the nature of injury S&T codes, it can be a most responsible diagnosis for a hospitalization. So the most responsible diagnosis is assigned to whatever disease or condition results in the greatest consumption of resources for that particular length of stay. On the other hand, the external causes, they're available for the same years, but they have a diagnosis type of 9, and they can never be a most responsible diagnosis for the hospitalization. So when you look at something like diabetes, many times you're looking at what is the what are the hospitalizations where diabetes is the most responsible diagnosis. You can't do that for external causes of injury. They can't be a most responsible diagnosis. And there can be multiple external causes per hospitalization. And, for example, someone could fall and then be hit by a car, and both might be reported at the admission. For emergency data, exactly the same thing, but the data availability, we only started reporting emergency visits in the National Ambulatory Care Reporting System, NACRS, in 2001. And so for 2001, it's just ICD-9, and then 2002 on is ICD-10. And it's the same structure as it was for hospitalization, in that the nature of injury codes can be a most responsible, or it's called a main problem diagnosis in emergency, whereas an external cause, a B&Y code, can only be an other diagnosis, can't be a main problem diagnosis. And then you get to deaths. So we have vital stats, and we actually have vital stats from 1986 on. So we have a very complete set of death data. And but for the nature of injury codes, which from 1986 to 1999 we used ICD-9, the nature of injury codes are available in the vital stats for ICD-9, but they are not available for ICD-10. And that is an issue that we've brought up with Ontario Registrar General and with Statistics Canada, but there doesn't seem to be any hope that we will be getting those codes anytime soon, if ever. So from 2000 on, you can't say X number of people died of neurotrauma. You can only say, on the other hand, as opposed to hospital data where the most responsible diagnosis is whatever has to be treated, in the death data, the primary cause of death can be an external cause, and that is the only injury data that's available in vital stats. So from 1986 to 1999, we have the E codes from the ICD-9 diagnosis for deaths, and for ICD-10 we have 2000 on to the current year. Currently 2007 is the most recent year available. There's always about a 2 to 3, now it's almost 4-year time lag between in when we get the vital stats database. So right now we're working with 2007. Hopefully, maybe even this summer we'll get 2008 and 2009, but probably only 2008. But you cannot, from querying the death data, tell how many deaths there were by a certain type of injury. You can only say there were a certain number of deaths by the external cause of injury. So motor vehicle, falls, etc. We have that data. And then for the only other database, administrative database that the ministry holds, which is home care data, that has any ICD-9 or ICD-10 coding in it, and that's the home care database. And it uses ICD-9 codes, but only the nature of injury codes. So it would have the head injury, the neurotrauma, the fracture, the hip fracture, but there's no data available in that data set on what caused the injury. So if someone's receiving home care after a motor vehicle crash, we can't get that information from the home care database itself. But because we have many other administrative data sets available within our data repository, and because every single data set that we hold, except for vital stats, has the health number in it, encrypted in the same way, we don't have the actual health number, we can link the administrative data sets that I talked about, where there is external cause of injury data, to these administrative data sets that don't have any external cause of injury information in them. So inpatient rehabilitation, the National Rehabilitation Reporting System, NRS, the home care database. So even though it has the nature of injury, we can also link the external cause of injury to that data set through the patient's health number from DAD or NACRS. The acute inpatient psychiatry, OMERS, it's also available for linkage with the with DAD and NACRS, and actually it's kind of before 2006, the patients that were in acute psychiatric units were actually reported through the DAD. So up to 2006, you can get external cause of injury data for those patients, but after from 2006 fiscal year on, you can only get external cause data through linkage with NACRS. Then complex continuing care, that's the continuing care reporting system. It's available to us. Long-term care, those are actually reporting through the same system, but we have them in separate data sets within our data repository. And then physician services, we also have in our data repository, and this is just the fee-for-service claims from the claims history database within the ministry. But same thing, it has the patient health number, so you can link to the other administrative data sets. So how have we used, and can you use these administrative data sets to look at external cause of injury or the preventable injury in the province? Well, you can evaluate the effects of policy. In 1995, well actually April 1st of 1994, graduated driver licensing started in Ontario. And it was started to address what had been discovered from looking at injury data in the early 1990s, and that is that the 16 to 19 or 16 to 20-year-old and well actually 16 to 24-year-old population had very high motor vehicle crash death rates and hospitalization, and we didn't have emergency data to look at that point in time, but we knew that this was a problem that had to be addressed, and Australia had already addressed that issue through graduated driver licensing, and so Ontario implemented a graduated driver licensing system. Their system was slightly different than Australia's. They don't have the two-tiered where you graduate from whatever, I don't even know what they're called anymore, G1, and then you have to wait a while longer before you try a test to get your full G. They don't have that two-stage process, and it's unclear how beneficial that has been. But the data indicate that since graduated driver licensing began, that those particular population groups, 16 to 20 and 21 to 24, seem to be showing a downward trend. And the whole idea behind graduated driver licensing wasn't just to reduce fatalities and collisions, crashes, hospitalizations for that 16 to 24-year-old age group. They're saying they are drivers on the road, so if we do this, everybody is going to benefit. We should see improvements throughout the motor vehicle crash statistics. And it clearly seems to have had some benefit. It's a little worrying that there seems to be an upward trend, and I'm thinking, and there's no way of testing it because we don't have it, that this is handheld devices and the impact of, because they're not included in any way within graduated driver licensing. Sorry.
One of the challenges of doing before and after analysis is treating the cause, and if I didn't see where the arrow was for graduated driver licensing, I would say that red line has been was already trending down before the intervention. Yeah, and in another slide that I did for this, I actually had
other points on it where, I mean, from 86 was the start of mandatory seatbelt legislation too. So you're seeing many effects in this trend line, and you're right. It's like what we would have to do is pull out those who were actually involved in graduated driver licensing, because graduated driver licensing, although it mainly impacts the young, it also impacts immigrants. Anyone coming to the province and getting their license for the first time has to go through graduated driver licensing. And it's done at the same time that we were doing other things like lowering the legal drinking limit, etc.
And secular trends in the social acceptability of drinking and driving also.
Right. But you could explore that through the administrative data sets. This is just like a glimpse of kind of the possibilities, what data we have and the trends that you can possibly look at. It will be interesting to see what happens now that there has been a cell phone law enacted as of last year, whether we'll see another trend down. And this is rate, and what isn't considered in this rate, this is just a population rate, is the whole idea that there are far more cars now. There are far more licensed drivers. So this is the true population denominator should be the population of licensed drivers, if we're just looking at drivers. And this is also looking at, because we know that the impact was also for females was being an occupant of a car, whereas males were more likely to be the driver of a car. And so it was, because of what was involved in graduated driver licensing, it was supposed to have an impact on both. And you could also look at males and females separately. Yes. No significant conclusions that I'm drawing from this. It's just an example of how you could use the administrative data. And then it's just the overall population health status over the years, and I only use 2000 to 2007, but I'll look at transport, falls, and suicide, and this is the total number of deaths. So it's not a population rate, but the population. So population increase is going to factor in as well, and you see that whereas in 2000. It was, more suicides, but not that many more than motor vehicle. But falls was quite a bit lower. And now you see the reverse. Well, suicides, motor vehicle has declined, and this is number, so the rate would be even an even greater decline because the population has grown. But falls are now so much higher than and. The next slide.
Does that have to do with the aging population?
Yes. And so and this is just total number, not saying what age is affected. But then burden of disease. So if you look at, okay, what is preventable? And so sometimes they use potential years of life lost, which is your age at death subtracted from 75. Not quite sure whether you use 75, they might be increasing that a bit since our longevity has increased, but that's the standard that's used. And you'll see that falls is way down here. So whereas the number is increasing, obviously the number is increasing because we have an aging population. And the potential years of life lost for motor vehicle and suicide are much higher than potential years of life lost for falls. Suicide and motor vehicle are mainly a disease burden within the young adult population, and falls very much the elderly population.
JoAnne, are these standard updated reports that you can pull off in telehealth? You
Right.
can query it and get this report?
Yes.
Yeah.
Yeah, there are some ISIS licensed users, but in telehealth for ISIS researchers tends to be not, ISIS researchers usually aren't that interested in just running a report. They're interested in querying the data and doing things with the data, and it is designed, in telehealth in particular, as a reporting tool.
No, it's great,
Yeah.
and it will report years of life lost, isn't it?
Mm-hmm. Yeah.
That's
That
great.
is that's a standard measure in the death data set. So you can just pull in potential years of life lost or number of
That's
deaths,
great.
and average age at death. There's a number of pre-calculated measures on every record and it is, all of these administrative data sets are record level data. We're not, although we have some data sets that are pre-aggregated, are cube-based for faster reporting, they're pre-aggregated from our base data sets, and all the record level data sets are available to all the licensed users.
And forgive me for this,
Yeah.
but if you query the database, say for that report, each time you query it, does it go and do the actual calculations, or does it cache the results for the next person who calls up the same report, so it doesn't have...
You can, the Health Analytics branch has created a number of what we call predefined reports. And then we save them as read-only so that nobody can mess with them. But we also save them as data can be manually refreshed. So they run very quickly with the last data. And we usually use the most recent year, but then you can refresh the data and prompt for a different year if you want. So this is just, this slide gives you an example of what I was talking about linking and how you can use linking with different data sets to actually do more advanced analysis. This one was around calculating, it was actually the insurance industry that wanted us to look at how much motor vehicle crashes were actually costing the healthcare system. And so we first of all queried the hospitalization data, but from that data we got the length of stay of each motor vehicle crash victim, and we got both the length of stay in a ward bed and in an ICU bed and the facility they were in, and then calculated those hospital costs by individual from their ICU stay plus ward stay for that particular facility. And so the total bed costs, you can see here, it's quite a significant burden to the hospital care system, $58.9 million and that was in the 2008-09 fiscal year. So they didn't want us, they wanted us to give the cost for that year. They didn't want to say, the lifetime cost of that particular patient. So that's how we structured it. But then we could, from that, link the patient with inpatient rehab data, the NRS data, through their health number. And we found that 842 patients were admitted to rehab after a motor vehicle crash, and that resulted in 32,000 days in that particular year, and the cost was $19 million to the system. We also, as I said, have long-term care data. It's reporting through the complex continuing care reporting system, and as of October of last year, all long-term care homes in the province now report through CCRS. So the linkage with them, there were 10 patients that were admitted from acute care following a traffic accident, 485 days in 2008-09. Though they're obviously going to be there for longer than the 1 year. 64,000 in costs. Then we also did it the same way, linked with home care, to 2,000 plus patients admitted, and their stay in home care was that many days. We can also, it's not shown here, we're just in the process of doing this, and we can also determine the number of services they receive in home care. So, and the cost of those services, the different types of services they receive.
Does this include long-term care costs for people injured prior to the fiscal year?
No.
So if there's a collision, in 2006, say?
Yeah, no, this was just for those who were discharged from acute care hospital in 2008-09.
Is it
So it's
possible
just
also?
those. But you could do it historically.
Is it also possible to calculate the present value of the future long-term care that is expected
yeah.
to be received? Okay.
Yeah, yeah, they just, as I said, wanted it for the 1 year, but you could project out based on survival rates of the particular type of injury they had, or.
Okay.
And we do have, going forward, we do have all of their record level data in long-term care. So we, have all their assessments and conditions and, et cetera.
Okay.
There isn't any service information other than, whether they've received dialysis or types of treatment like that. So, and emergency visits, the case weight is available. We haven't done that part of the analysis either, but you can see there were 96,000 visits, so we could calculate the cost of those visits from their ambulatory case weight. So the total cost of just what I mentioned, both hospital plus inpatient rehab plus long-term care, $78 million in 2008-09. So good arguments for injury prevention. And that gets me to the Haven matrix for injury prevention. And I've just got up here, this is the Haven matrix. It has the event phase for the external cause of injury, and then the host, agent, and environment factors. And I've just listed some, you could expand on this. This is just, briefly what the type of information you could get from the administrative data, but within each of those, cells, what you could get from the administrative data. So alcohol use, pre-event factor in motor vehicle crash, also in falls, probably in many external causes of injury. You can get ICD-10 diagnosis information from the emergency visit or the hospitalization, either as a most responsible or a secondary diagnosis. Usually would be a type 1 or type 3 or 4 diagnosis rather than a most responsible. You can also get repeat visits because it's record level data and you have the health number. We could look at repeat emergency visits for someone who attempted suicide. And it might not just be for the suicide attempt, but you could look at repeat visits for for psychiatric disorders prior to that. Type of vehicle as an agent or vector. The ICD-10 codes specify the type of vehicle, whether it's all-terrain or a truck or a bus, etc. Place of occurrence, so that can be a factor. And with ICD-10, there are what's called U98 codes that are available with every external cause of injury diagnosis. There is a corresponding U98 code, except for motor vehicle, or traffic, I should say. Traffic gets considered to happen in traffic, so there is no U98 code associated. But for for all other external causes, there can be a U98 code assigned, which is the place of occurrence. In all of our data sets, we have available various levels of geography that are added to the record level data that we receive from CIHI or whichever source. So we have the LIN and the public health unit, all the way down to postal code. We have census tract and other census geographies as well. So that can be examined. Event factors, there's our fields in NACRS in the emergency visits for seatbelt use. So seatbelt use and you can identify motor vehicle occupants and look at seatbelt use, and also helmet use. So you can identify motorcycle or pedal cyclists and look at helmet use. And then age and sex are always event factors. For falls, you see the elderly, it's a factor in that particular external cause of injury. And age, single year age, not birth date. We can't have birth date exposed to the licensed users because it's personal information. But we have single year of age, as well as 26 different age groups that you could break it down into from the data set. And sex is available as well. And then post-event where they end up, like whether they end up receiving home care, etc., is available, but also pre-existing conditions you can get from dad and knackers if they're reported at the time of the visit or the hospitalization. Also in OMERS, the social situation information is available because they are psychiatric patients, so you can get at some of that. Environment, you can get whether they arrived by ambulance and by what type of ambulance, and the location of the hospital ED to the patient location or the location of the incident. And you can also get the ALC stay, which is an important consideration. Many times, or we know that ALC, the alternate level of care problem is a huge one in Ontario. And there are many elderly that are in ALC beds because of a hip fracture from a fall. But you can look at that sort of information. So I'll just give some examples. This is, you saw suicide. I'm going to focus on those main three: falls, suicide, and motor vehicle. You can get the means of intentional self-harm for deaths versus emergency visits. So I just broke it down, and that's because the breakdown within the ICD-10 code allows you to identify the means of suicide. So you can see that when you look at something like poisoning, 80% of emergency visits for intentional self-harm were a result of poisoning, whereas only 25% of deaths. And you see this difference in vital stats, in the difference in suicides between males and females. Females are far more likely to use poisoning as a means, and so they're more likely to end up in emergency, whereas males are less likely to use poisoning, more likely to use lethal means, and there are far more suicides for males than females in the province. And this is just looking at by type of transport, and here I have broken it down into male and female. And you see car occupant, females, there's actually more than males. And this is emergency visits again. But every other type of vehicle, it's males that are predominantly the victims of the particular crash.
Just a question back on the suicide slide, the one just before. Did you find that, if you found that more males than females completed suicide, did you find that there were more females than males in the emergency as well?
Yes. Yeah. And and I should also point out that these emergency visits are not, exclude the ones that were dead on or after arrival. So it is not, there aren't any deaths included in the...
Do you know what the ratio was, the gender ratio was for that?
I can easily get it for you. Yeah. I think it was like 4 to 1 for deaths, and almost the reverse for emergency visits. But I can quickly send you a file. I do have it.
Thank you.
But this is the kind of question you can ask of the data, and so type of transport. This is the hospitalization rate for hip fractures resulting from fallen seniors, and looking at it across the province, where is it a particular problem? So as I said, the geography of the patient is available on the record level for all of the data sets. So you could also say, how many hospitals. You could look at it by hospital and say this many hospitals are seeing seniors come through their doors with a hip fracture. But probably in terms of prevention, it's far more important to look at where the patients are living and where do they have particular problems in the province. And this is by the number of the LIN, but the purple are Toronto Central and Central, so they would be the City of Toronto area in particular. So we do have. And this is rate, and you just see how high that rate is. And this is per 100,000, but so 600 per 100,000, that's like, those are very high rates. And Ontario, for about 450 per 100,000. So it's a huge problem. And this is just hip fracture resulting from a fall. Then you can look at, for falls, a place of occurrence. That's what I was mentioning, those U98 codes that are available with every external cause of injury, with the exception of transport, which is assumed to be in traffic, so it doesn't have a U98 code associated with it. But for falls, and these are falls that ended up with a hospitalization. And you see that the home is the main place that seniors fall. And this is seniors, 65 and over. So you could look at this in kids, where are they falling? The place of occurrence includes playgrounds, includes sports fields, so you can look at place of occurrence for falls in that way as well. But you see also that there's a large 21% don't have the place of occurrence or stated as unknown. So, but it's mainly our houses, and seniors presumably have been living in the same place for most of their lives. So it may be factors other than the environment that are influencing falls, such as function, level of function, etc. So pre-event host factors, this is looking at emergency visits for neurotrauma and looking at seatbelt use. So you see that there's a large, it's not a mandatory field in NACRS, so there's a large number of unknowns. But still, when you look at it, like why isn't everyone using seatbelt? I mean, it's, and so, and you see that there's, up to almost 20%, 15 to 19-year-olds that are hospitalized with, or emergency visits with neurotrauma, were not wearing a seatbelt. And this is only motor vehicle occupants that we're looking at. So you can filter out for just those codes related to motor vehicle occupant. It's not easy. It's not unlike ICD-9, where E810 to 819 was motor vehicle. Here with ICD-10, you have to, it's like this range of codes with a final digit of 3 or 4, and this other range of codes, and these single codes. But it is possible, and it's really interesting to note that so many people still don't get the message that, just put on your seatbelt and you will be saving yourself a lot of heartache. This slide looks at the number and rate for deaths, but also hospital, and these are deaths that occur on or after arrival in emergency, because we can't get neurotrauma stats from the vital stats. But you'll see that I've put in highlighted, because there's a lot of numbers in this, but basically the people that are hospitalized with neurotrauma are far more likely to be elderly. And it's not shown by this, but in the research that we did around this, they're far more likely to have had a fall. Falls in the elderly. And in the early 90s, the major cause of neurotrauma, especially neurotrauma that resulted in hospitalization, was motor vehicle crash. So it's the pendulum has swung, and you'll see that emergency visits, well, they're most common in that adolescent population, probably sports, some sports related, motor vehicle crash. You saw there were far more in that age group. But the elderly are much more likely to be hospitalized or to die from neurotrauma. And these are just using that one particular data set. So this is just using NACRS data. So hospitalized is just the disposition status was transferred to acute care. And death is those who died on or after arrival. And then emergency visit only are the remainder. But it's the one particular data set, and it actually is cleaner data set to use because when you're looking at hospitalization, the hospitalization isn't reported until discharge. So when you're looking at a particular year, someone could have been hospitalized the previous year and discharged in that year. Whereas emergency visits, you look at it, it's a one-day event, and then they're either admitted to acute care, so you can get the hospitalized. The deaths on or after arrival you can also get. This is, again, looking at hospitalization for falls, but just to show you how the demographic involved in falls changes, and you see that the rate, or this is just the total number. So if you actually looked at rate, it would be an even steeper J curve that you'd see, because there's far fewer 85 to 90 and 90 plus year olds than there are in the younger age groups. But it's just dramatic how it's more of a problem. And in 0 to 9, it's fairly even between males and females. Kids fall. But then from that point on until the age of 50, it's mostly males. And then it's a sharp change, and falls in the elderly are mostly a problem for females. But that's mostly because we live so much longer. But also the frail elderly female is much more common than the reverse.
Hi. In the pie chart that you had a few slides ago,
okay, yeah.
you had the place of the fall,
Mm-hmm.
and you said home. The home is the most likely place to fall for elderly. Is that a private home, or does that also include a nursing home? Or
No, that is just home. That's
That's
just
just a
private
private
home. There is a
home.
separate residential institution.
Okay, so that's
Yeah.
not considered their home.
No.
Okay.
Yeah. But you can also look at, to make sure that it's not people in long-term care home facilities. We've also analyzed the data as where they're transferred from.
Right.
So, yeah. So transfer from long-term care home. Well, actually, that's kind of messy too, because it's transferred from, in Dad and Knackers, they're coded as nursing home or home for the aged. And it's they aren't, there isn't a long-term care home category. So when we do it, we only look at ministry-funded long-term care homes. So they have an institution number, and we select only those institution numbers to look at transfers from long-term care homes. But you could do it for all of them. It's just unclear how they code in the emergency, or in DAD, how they code in particular homes for the aged. It's like we tried to do it just looking at homes for the aged and nursing homes, and our denominator was greater than the, it was just an unbelievable denominator that we had as being in a long-term care home. And compared to the data we know from the ministry, which is that there's about 76,000 long-term care home residents.
But, so what about the private? Does that include the private ones?
No,
as
so
well?
we can only do
The
the
public
ministry
ones,
funded,
yeah.
because those are the ones that have institution numbers.
Yeah.
Now this is just comparing, just taking a look at emergency visits for transport and intentional self-harm by age group. And you see that intentional self-harm, if you remember back to the slide I did of deaths, where suicide and there was actually more suicides than motor vehicle crash deaths for the last 3 years. And the other years they were fairly close in number. But you see for emergency visits, intentional self-harm, there aren't nearly as many as emergency visits as there are for motor vehicle. And some of this can be around coding of intentional self-harm. So if someone visits emergency and it's a drug overdose, they can code it as an accidental overdose rather than code it as intentional self-harm. And it's probably more likely that, or they can code it as intent undetermined. And so you don't, you see this picture, but it probably isn't a true picture of intentional self-harm. And that's what you always have to be careful of when you're looking at attempted suicide.
Single-person motor vehicle accidents are also
Yes.
a method of suicide.
Yeah, yeah. But I don't think we saw it in a means, and it's really difficult to, I think with a motor vehicle crash, doesn't there have to be a suicide note for them to code it as intentional? So this is just an example of some of the indicators we're using right now. We have a ministry, it's called the Resource for Indicator Standards, where we have technical documentation for a wide range of indicators that are used throughout the ministry. And I just highlighted 4 that we're using right now that use administrative data sets around injury. So there's one for hip or other fracture in the past 180 days in long-term care homes. There's one in hospital falls with fracture. And then, so that's a patient safety indicator, so it's the ones that actually happen in the facility rather than occur, well, they could have had a fall before they entered the facility as well, but it's a post-acute care admission. Hospitalizations for falls and seniors transferred from long-term care homes, as we were mentioning. And then emergency visits for falls and seniors is another indicator that's in that Resource for Indicator Standards database. But there's any number of indicators you could look at using administrative data for external causes of injury.
I know in terms of resource planning, just counts, maybe it was helpful because you need to know how many beds. But in terms of analyzing cost and the impact of programs, rates are more important. So do you provide age-sex standardized rates for these as well as the counts?
Not from IntelliHealth, because it is a record level data set. So when you're querying it, you're querying at the record level. So the system doesn't see the aggregated data to be able to calculate rates. But we do have some, and there is an intention to do more in the future, pre-aggregation, so cube-based data sources that include rates as well. We have one for death rates and ranking of death by age group. But you know, potentially we could do that, but because it's record level data, we don't have that. So we have are you familiar with the ambulatory care sensitive condition indicator from CIHI? So we provide a report that allows people to get the numbers and get the population, and then they have to calculate the age standardized rate themselves. But the intention is at some point to have more of the, but there's just so many data sets that we are managing that it's, and every time you think, okay, we'll just provide a report for this particular indicator, but then there's, as soon as you do that, there's just such a demand for the same type of thing for any number of the 200 plus indicators we have in the Resource for Indicator Standards. So it's mainly for reporting numbers, and you can download the record level data to do the linking or to do further analysis as well.
JoAnne, thank you very much. It's really, really helpful to have the opportunity